So good evening and good morning, good afternoon to people those who are in different time zones. And today we wish to uh, discuss a recent diastolic. Good morning, good afternoon to people those who are in different time zones. And today we wish to uh, discuss a recent diastolic. Good morning, good afternoon to people those who are in different time zones. And today we wish to. Uh, I'm sorry for that. I think now things should be all right. Okay. So I begin again here. Okay. We have a great pleasure to welcome you all today's webinar on latest guidelines on diastolic functions and heart failure with preserved ejection fraction published this month only by ACC. And whether you are a sonographer or practicing echocardiographer, a cardiology fellow, or a senior DM cardiology, I think your presence here itself indicates that your commitment to a continuous learning. The diastolic functions remain a nuanced and evolving area in echocardiography. And staying updated in this latest recommendations are essential. And we would keep bringing in case something new comes up. In this session, we aim to actually simplify all the complexities of new diastolic guidelines, and we would try to maintain the scientific rigor that advanced practitioners expect. So, through interactive discussions, and we would have case reviews and practical tips, we hope that we'll be able to enhance your knowledge for a clinical decision making. And we do recognize that there is diversity of experience and roles among our participants, starting from sonographers to advanced DM cardiology people, those who are doing echocardiography. So we'll try to do justice for both. And once again, thanks for joining on this. So I would be the first speaker, and I would give you an overview of the guidelines, how the guidelines are evolved, and I would take you through following various steps. We would introduce you to new guidelines, and then diastolic parameters, each by one of them. I'll tell you how to do it and what is their relevance. We would come down at the end of the parameters by the algorithm which has been suggested by these guidelines, and we would discuss as a case study or also as a diastolic stress echo that would be close to end of the presentations. So we would also discuss because this is hallmark of the guidelines, that they have included special situations: atrial fibrillation, hypertrophic cardiomyopathy, mitral stenosis, aortic regurgitation. Practically all special situations they have included in this. And then I would discuss about heart failure, preserved ejection fraction. This comes from a Methodist hospital, and very good senior people in diastology are involved in it, which includes Dr. O and one smart thing they did was just a month before, that is in June, they published a very interesting study that they applied the algorithm which they gave us in the guidelines. They applied on the patient and saw how effective it is. So what they did was they did about echocardiography in about 1,000 patients, those who were recommended for cardiac catheterization, and they used algorithm by the current guidelines to assess those patients' diastolic functions within 48 hours of doing a catheterization. And only two patients. Now that was very interesting. Our previous guidelines had a issue that many patients would fall in an intermediate category where we would not be sure what are we dealing with, and that's what happened in this. They applied 2016 guidelines, and intermediate category was about 38 patients versus two patients with the current guidelines based on cath data of LV dysfunction. And in the rest 949 patients, the sensitivity of picking of diastolic dysfunctions was about 86%, and specificity also being the same. I'll show you the chart on the subsequent slide. And it was seen that is far more accurate than 2016 guidelines with a significant p value. So they also, try to say that there is a good incremental value in case you add BNP to the guideline to the current diastolic parameters, but they do not figure that in the guidelines. Uh, showing you the new algorithm based on a cath lab, and what they did was, if the cath was done within a day or the cath was done not on the same day, they found almost the same sensitivity and specificity. It wasn't really very different whether they did cath on the day of this thing or little later. But as compared to the guidelines on 2016 with ejection fraction of more than 50, this is again heart failure with preserved ejection. People, sensitivity was lower, specificity was lower, and it was better in our newer guidelines. And the accuracy, this is what about, if you talk about patient those who had ejection fraction which was on the lower side, we're talking about heart failure with reduced ejection fraction. There wasn't a great difference. It was not statistically significant between the past and the current guidelines. So difference was in patient who had an ejection fraction more than 50%. The addition of anti-pro BNP really improved this green line, improved the area under the curve. So from there, they said, okay, let's bring down the guidelines. And the July this year, the guidelines were published. We discussed the various parameters, what we need to do and what we should do. The mitral inflow should be taken at the tips of the mitral valve with the sample volume of about a centimeter or a centimeter and a half. It should not be less or more than this. Ideally, the peak E velocity is taken, the deceleration time is taken, the A wave is taken, and mind you, all this is taking on a modal velocity, which means the chin, not the beard, which we have discussed a number of times. So apart from that, we take an A wave duration here, which we would put it with the duration of the pulmonary A wave and for the further interpretation. Now we have these are the normal and abnormal values, which is no rocket science, is there for quite some time. Then we take a mitral annular velocities, which we know how to do it. Medial and lateral annulus, you got to be as close as possible to the annulus, and the sample size should be smaller. It should be less than a centimeter, preferably half a centimeter of a sample volume to take a lateral, and this thing reduce the gain setting so that you see a nice modal velocities of E and E prime. Again, all the measurements are taken at the modal velocity. This is modal velocity, and then we take mitral E and A ratio and we average them out. These guidelines have given a lot of importance to E prime velocity of a medial and lateral, and they've chosen this as number one step. And this is not longer being a very important parameter now. We would discuss in the guidelines. Now, left atrial volume can be done by a three-dimensional echo, preferably if you're using a two-dimensional echo. A Simpson disc method can be used both in in four-chamber view and two-chamber view, and the idea is that the difference of length should not be very different in both the views. So we know now the recent guideline says 34 ml per meter square is the volume we are taking. And the peak TR velocity, again, it's taken, we used to take in the inspiration the velocity, but the guidelines recommending that averaged over the respiratory cycle. There is still a confusion whether you should take an inspiration or an expiration tricuspid velocity, because many a times it does vary a lot, but the guidelines say you average them out, and that's how it is. So, pulmonary venous flow, the sample is taken about a centimeter or half a centimeter inside the right upper pulmonary vein, and the sample size also should be smaller. And then you get an A and the S and a D wave. Normally, S is larger and the D is smaller. And then you have A wave. You take the S velocity, D velocity. Also, you can take a VTI of both. We would tell you later. And then you can also take the A wave duration. And the abnormal values are if SD ratio is less than 1, or specificity if it is less than zero point 0.7, and the VTI of S is about 40% of the D, and AR duration and this thing is more than 30. I prefer that you go through the guidelines in detail, so that will save our time in discussing these small nitty-gritties during this talk. So now we have these parameters for an IVRT, and how do you take an IVRT? It is the isovolemic relaxation time. You take it from end of the systole, which is end of uh, the V wave, or an aortic flow velocity, and the beginning of the E wave. So this is where you take an IVRT. A shortened IVRT indicates elevated filling pressures. This again has a resurgence into a clinical scenario, that is velocity propagation. You take a sample from cursor here and 4 centimeters towards the apex, and then you see the slope of this VT. You can actually do it with the normal Nyquist limit, or reduce the Nyquist limit like we do in PISA, so that you get a nice interface between the two colors, and you can take the slope, and the slope of more than 50 is abnormal. Normal less than 45 is abnormal. In this patient, the slope was 36, was abnormal. And then you can take E and VP ratio, which is more specific for diastolic dysfunction. Then E and I prime distance, what we do is that we, from the R wave, the of the R wave, then we take the distance or a beginning of an E wave of the mitral, and we use R wave as again as a reference, and take a distance of the E prime, the E wave and E prime. Now, E wave comes first and E prime comes later, and then the difference between the two, in case it's increased, that indicates a diastolic dysfunction. The E wave comes with the rapid filling because of the pressure gradient, and E prime comes because of the ventricular relaxation. In case the ventricular relaxation and filling are not as synchronous, there is a delay that can cause a feature suggestive of a diastolic dysfunction. This is again as a very important parameter which wasn't there in previous guideline. It was optional, but I think we should use it. Less than 18 is a kind of a cutoff limit for a reservoir strain for left atrium. This is There are many parameters which are age dependent. This is one of the parameter which is age independent, that is mitral flow changes, inflow changes on Valsalva. What we do is we ask the patient to blow in one pipe. We disconnect this from the cuff, and we ask the patient to blow in this, and the patient has to keep it about 40 millimeter of mercury, and that's what is Valsalva. And during Valsalva, if there is E to A ratio which falls more than 50%, it's kind of specific for that. We have EA was pseudo-normalized, and you bring out an abnormal relaxation pattern with this interesting phenomena. I'll try to rush up because of the time. Now, I am presenting a case of a 62-year male who came with a dyspnea, hypertension. There was a left ventricle hypertrophy. LA was enlarged, and there was a mild mitral regurgitation. But you notice on this panel that there is in between a wave between E and A wave, and again, which is markedly better seen when there was a little more bradycardia, and this wave is a mid-diastolic flow where actually there is a diastasis and hardly any flow from LA to LV, and this is called an L wave. We said that L wave is of importance in case it's more than 50. Then the guideline came, it can be important when it's 20. Now we believe that any presence of an any L wave is of significance and looked at carefully. Why, after all, we call it L wave? Where did L come from? The L came from because initially we said that there was a K wave and an M phase, K phase and M phase in the pulmonary venous flow, and L came between these two. These were the original 1991. Dr. Tajik and O described this as K and M phases. Now, these are more common in hypertension and in hypertrophic cardiomyopathy, females for some reason, and atrial fibrillation, and the sensitivity and specificity of diastolic dysfunction is about 94 to 88% in case you find an L wave. So L wave, I think, should be looked into in case of a bradycardia. It would be very useful, though it was described for the first time in the normal people by Dr. Karen, and this is his publication 1986. And there are mechanisms given for an L wave. We would not go into that discussion, but that's a review article which is not very old, describes the this is very nicely, showing you just one or two examples of a L wave. This is the concentric left ventricular hypertrophy, mild dilatation of the left atrium, and go back, and then I show you this is the L wave, which is again about less than 40 centimeter per second. But you notice L wave in mitral valve, you notice L wave in the tissue Doppler, and you notice L wave. This is the flow, this is the mid diastolic flow. E wave and A wave reduce the Nyquist limit, and you can see the mid diastolic flow, which is a marker of an L wave. Again, a patient with the left ventricle hypertrophy and LA enlargement. And now you see there is an L wave. We notice that the E to E and A ratio is more than 2. It's severe diastolic dysfunction anyway. But you see an L wave. You see an L wave on M mode of mitral valve. Many a times L wave can be set better seen in one parameter or in another. We don't know the reason why it's sometimes shown better on the mitral valve M mode and sometimes better on tissue Doppler. Now, this is again the L wave, which is less than 50 centimeters, but you notice there is an L wave on the mitral M mode. And there's another patient showing a mitral M mode on the mitral valve, and you seeing this is a curved kind of pattern. But once the bradycardia is there, you see this L wave, and you see L wave in the. Okay, this is the patient with the regional valve motion abnormality, a scar. The image is not too great because of the patient's poor acoustic window. And you see this is a scarring here. The LV dysfunction was there. And if you notice, this is the E and A. You presume that this is an A wave. Actually, the A wave is not here. This is atrial fibrillation. And what you see here is an E wave. And again, that is proven by the L wave that you see in atrial fibrillation. Many a times there is a confusion in atrial fibrillation. Are these fibrillatory waves or these are the L waves? I presume the fibrillatory waves, they kind of superimpose sometimes on the L wave, giving this kind of picture. This is an L wave, this is an L wave, but these are the fibrillatory waves markedly seen on an M mode of a mitral valve. So I'll skip this. And now I'll give you the algorithm of evaluation of LV dysfunction. Now, if we have a reduced E velocity less than 6 and a lateral less than 7, that should be step 1. And increased E to E prime, that stands the same. In the previous guidelines, the TR velocity stands the same. But these are the three things which initially we used to take the LA volume here. Now, all normal, reduced E wave, or there is an increased TR velocity. Now, first thing, if they all are normal, then the probability of having normal LAP is very high. Let us presume there's only E wave is abnormal and other two waves are fine. So then in case to E to E prime is okay, then it is normal. If E to E prime is more than zero point 0.8, then you can still consider a diastolic dysfunction. If you have increased TR velocity, which can be there because of many reasons, or only you have an increased E to E prime, that has to be taken carefully. We may not be able to make a diagnosis only based on E to E prime. And then you have to use further methods to make an assessment of the diastolic. In case all three are present, we don't have any doubt of increased LAP. And in case the patient is symptomatic, there is a grade 1 diastolic dysfunction, you can ask for an exercise. And increased LAP can be graded into grade 2 and 3, depending in case E to EA ratio is more than 2. Special situations in atrial fibrillation problem, there is a lot of tachycardia, there is absence of an atrial contraction, and the cycles vary. And there is already an LA enlargement because of atrial fibrillation. So you have a limited number of parameters which we can use. You can use the deceleration time in these group of patients. You should do IV-RT in these patients. E to VP ratio is very, very important and can be very easily used to classify. So in the estimation, what we do is that we do an E velocity if it is more than septal E to A ratio more than 11 and a TR velocity more than 2.8 or a DT less than 1 or deceleration time of E is less than 160. If none or 1 is present, then you can say this is normal LAP. In case all three or all four or three more than three are present, then elevated. And then in other situation, you can use other parameters like pulmonary S and D ratio to finalize the diagnosis. Annular calcification, again, because of the annular calcification, the orifice is reduced. There is an increased E velocity because of that. And E prime is reduced because it's calcified. The annulus is not moving. So E to A prime is not accurate. And in this situation, we use this algorithm to reach the diagnosis. In hypertrophic cardiomyopathy, Dr. Vinayak would show us a case where we take an average E to E prime as a main important thing, and the difference between pulmonary A and mitral A more than 30, and peak TR velocity and LA volume. So these are the parameters taken for hypertrophic cardiomyopathy. In the sinus tachycardia, when the E to E prime are E and A are fused, then we use an IVRT that can always be used. And then we use annular to in the reduced velocity, because if you use the annulus many a times, the E and A can be separated easily. In the mitral stenosis, we use IVRT, that is the best way, and IVRT to TE prime ratio is the most important parameter for diastolic dysfunction. In mitral regurgitation, there is not much difference between the regular guidelines. A heart failure for preserved ejection fraction is diastolic dysfunction plus features of heart failure, or in the previous guidelines you have a raised anti pro BNP, but we now know raised anti pro BNP is not necessary to make a diagnosis. In obesity, the anti pro BNP can be normal or low in heart failure with preserved ejection fraction. So thank you very much. I know I overstepped the time, but I think we can continue the webinar little longer. So I'll stop sharing here and check in case there is any questions in the session, or you can keep posting the questions. Maybe we would answer the questions after Dr. JC Mohan's talk, and then we'll show cases. Is that okay, Dr. JC?
Yes, it is okay.
Yes, sir. I think you can share your screen and you can proceed with your.
Thank you, Dr. UP Singh, for inviting me for this interesting webinar. And I'm going to, I think I will touch upon the new guidelines, but I will also compare it with old guidelines and also the guidelines framed by British Society of Echocardiography in June 2024. So why diastolic function is gaining ground? Because we can study the cardiac physiology with respect to risk factors, diagnosis of HFpEF, for prognosis, recovery, and remission of heart failure, and it's a potential therapeutic target. And as an endpoint for evaluation of novel therapies, diastolic function is gaining ground. Heart is engaged in a rhythmic sequence of contraction, relaxation for organized propulsion of blood to the next chamber. Flow is cyclic, sequential, and valve-directed, unidirectional. What we are interested in is how filling is taking place. Is the filling adequate or not? Are the phases of filling proportionate? And how much of filling is taking place? That is all about diastole, and at what cost of energy filling is taking place. That is really studying the diastolic function. So diastole is a period of relaxation, expansion, and has four phases: isovolumic relaxation, rapid filling, diastasis, and atrial contraction. And of course, there are some diastolic phenomena which we are familiar with. The first thing, a recoil due to stored potential energy. Then there is a relaxation of myocytes. There is both the things lead to active suction, and later on, of course, there is an expansion as because of the viscoelastic forces of the ventricle, the filling takes place, and all these phenomena have bearing on the diastolic function. So in general, left ventricle volumes increase as filling increases and the left atrial volumes decrease. During this process of diastole, the LV diastolic pressure is slowly rising and there is a biphasic mitral flow. And of course, the left atrial volume keeps decreasing during diastole, and so is the left atrial pressure. We have discussed a lot about isovolume relaxation time, but suffice to say that this is not tau, is not the constant of relaxation, and it actually is one phase which gives you an idea about diastolic function, and it changes biphasically. That means when it is short, it indicates increased left atrial pressure, and when it is prolonged, it tells you about impaired relaxation. So let's try to understand what happens actually in diastole. The initial part, you would just correlate with the ECG shown at the bottom, and you would note that the initial part there is a relaxation which goes on till maybe mid-diastole, but it decreases. And in mid-diastole to later part of diastole, you would see that the myocardial stiffness increases because of viscoelastic forces. And the two phenomena together essentially define diastolic function or diastolic dysfunction. There are separate denominators for relaxation and myocardial stiffness with a good amount of overlap. Of course, pericardial constraint also plays a role throughout diastole. We have talked about the grades of diastolic function, the early stage of impaired relaxation, grade 2 normal or pseudo-normal, grade 3, which is restrictive flow pattern, with E to A ratio being more than 2:1. Let us now quickly recapitulate 2016 ASC ECVI guidelines on assessing diastolic function. As was told by Dr. Singh, initially, the first thing you check is left atrial volume, more than 34 ml per meter square. Once you see that, then of course you look at the other parameters. But in general, if you look at all the four parameters, if there are, and now here comes the difficulty. If there are two or less than two factors abnormal, it is normal diastolic function. Now it is difficult to digest that E to E prime ratio of more than 14 average as a single parameter would be called normal, but that is what those guidelines were. And of course, if there were more than two, that means three or four parameters, it was presumed that diastolic dysfunction is present. And when you are dead at center, 50% abnormal, you would call that as indeterminate, and further tests would be required. Or further, you would look at the pulmonary veins, you would look at the other parameters. But this was as far as the diastolic dysfunction patients with normal ejection fraction. The same guidelines said that in normal ejection fraction with myocardial damage or with ejection fraction less than 50%, this was the classic algorithm. Grade 1 diastolic dysfunction, normal left atrial was when E to E ratio less than 0.8 and E was less than 50 centimeters per second. Pretty clear. And of course, the grade 3 diastolic dysfunction on the extreme right with increased left atrial pressure was also very clear. All you needed was E to A ratio more than 2. And remember, all these were studied in relatively elderly people. And of course, these apply to individuals who are above the age of 45 years. That they had very limited data for younger individuals, but those who had an E to A ratio of 0.8 to 2 and E of more than 50 centimeters per second, you relied on three parameters, left atrial volume index, E to E prime, and TR velocity. If two or more were abnormal, it was grade 2 with raised left atrial pressure. If there was 0, it was normal. And if this was 1 out of 3, it was indeterminate. So simple way of saying. Unfortunately, a lot of people fell in that territory of indeterminate diastolic function, as Dr. Singh pointed out, and that was a major flaw of these guidelines. So these were the guidelines actually, and this is how we graded the diastolic function, grade 1, 2, 3, and we became quite aware that the TR velocity was increased in grade 2 and 3. The E to E prime was about 10 in grade 2 and grade 3. In normal and grade 1, it was less than 10. And LA volume was increased actually mostly in grade 2 and grade 3. In grade 1, it could be normal or increased. They also suggested, of course, in indeterminate cases to do a Valsalva maneuver, which has been discussed by Dr. Singh in detail, and atrial reversal velocity, which was more than 35 centimeters, suggestive abnormality, and AR duration, which was more than the A duration, AR duration of pulmonary. Okay. So what were the problems with 2016 ASC guidelines and diastolic function? Some of these have been already mentioned by Dr. Singh, but let me take you through those quickly. There were unacceptably high rates of indeterminate diastolic function, close to 30%. LA strain wasn't included in parameter, although for long it was considered that left atrial function is the barometer of diastolic function. E values proposed were regardless of age, and that was a major drawback. TR velocity was given an important status despite being difficult to ascertain good number of subjects. And we are aware of that. And especially validation against invasive parameters was modest. Now, Dr. Singh showed you a study with these authors did, and they showed it was fairly good sensitivity and specificity. But let me show you the other part of the story. The same group, not the same group, but same center, Mayo Clinic, they showed that the ASC-ECABI criteria actually had a sensitivity only of 34% and specificity of 83% when it came to diagnosing elevated filling pressure. And that is abysmally low sensitivity. The same, the Dutch study actually, which had simultaneous catheterization, also showed similar kind of sensitivity of 2016 guidelines when it came to talking about elevated filling pressures, which means grade 2 and grade 3 diastolic dysfunction. The sensitivity was 35%, specificity again was similar, 87%, and predictive accuracy of 67%. Those were two major studies which showed that sensitivity was pretty low. However, in another study, actually, the European Eurofilling study, they showed sensitivity and specificity was reasonable. So now here comes the problem. The problem may lie with the small number of patients studied, the kind of patient you have studied, which means the population you have studied. But nevertheless, one thing was clear, that ASC 2016 guidelines on diastolic function, when it came to diagnosing elevated filling pressure at rest, which is a marker of HFpEF or which is a marker of elevated filling pressures, the sensitivity was nothing to talk about. It was much lower than what one would expect from an algorithm. The Britishers actually in 2024 guidelines on diastolic function improved it. They included a left atrial strain parameter, and of course, they gave importance to less frequent phenomena also. They stressed on stress diastology. What was more important was they defined the E prime, which was age dependent, age and sex dependent to some extent, and which I think was a major advance with regard to evaluating diastolic function. So this was the British Society ECHO algorithm. They were still looking at all those three criteria. These are we are talking of individuals who have normal ejection fraction. We are looking at again three parameters: average E to E prime more than 14, LA volume more than 34, and TR velocity more than 2.8 meters. And if two or three were positive, it was still impaired diastolic function with elevated filling pressure on extreme right. On extreme left, if two or three were negative, and of course, by the age-specific E prime was also normal, you declared it normal diastolic function. Remember here, if the age-specific E prime was reduced, you called it impaired diastolic function with normal filling pressure. And in between was this so-called when there were only you could not assess all the three criteria. You could assess only two. One was positive and one was negative. Here, and that was a large group of individuals. In practice, that accounts for about 50% of all your patients. There you had to assess the left atrial strain. In case the pump strain was more than 14% or reservoir strain more than 30%, you said you would bring these patients to the left side, that is either normal diastolic function in case the E prime was also normal, age specific, or impaired diastolic dysfunction. However, in case this was not true, you again looked at the left atrial reservoir strain. If it was less than 18%, this was impaired diastolic function with elevated filling pressure. And in case the left atrial reservoir strain was less than 18%, wasn't present, You looked at supplementary parameters like ARA duration more than 30 milliseconds, L wave more than 20 centimeters per second. Remember here, the L wave is more than 20 centimeters per second and not 50 centimeters per second. Uh, uh, the, the algorithm went on to also find diastolic function in individuals who had ejection fraction less than 50% or those who had GLS less than 16% or known myocardial disease. Here, first thing they did was they said each of these individuals has diastolic dysfunction. So diastolic function is already impaired if you have ejection fraction less than 50%, GLS less than 16%, or you have known myocardial disease, because that would always be there. Now the question was to grade them further, whether there is elevated filling pressure or or there is normal filling pressure. And this went to, again, with the same three criteria, E to E prime more than 14, LA volume more than 34, TR velocity more than 2.8. Clearly, on the extreme left, if 2 or 3 were negative, it was impaired diastolic function with normal filling pressure. On your extreme right, if 2 or 3 criteria positive, it was impaired diastolic function with elevated filling pressure. Now, if all three could not be assessed and you could assess only two, largely most often TR velocity you would not get accurately, then you had to assess the left atrial strain. And if the left atrial reservoir strain was less than 18 or left atrial contractile strain was less than 8, one of the two. Now, this is important because this is different from ASC. The ASC 2025 does not take left atrial contractile strain, does not take in account. But if any of them was positive, then it was impaired diastolic dysfunction with elevated filling. If it were none, you would look at left atrial reservoir strain, and if it was more than 24% or left atrial contractile strain more than 14%, you will call it normal filling pressure with impaired diastolic function. And if this wasn't there, neither you had more than 24% and less than 18%. So you are in between 18 to 24%. What would you do actually? You will do supplementary parameters, AR to A duration, L wave more than 20 centimeter, pulmonary valve S to D ratio less than 1, and of course deceleration time of E wave less than 150 milliseconds. And if clinically indicated, exercise may also be considered. Now, these are the British Society Echo guidelines. How do they differ from ASC 2025 guidelines? We will discuss in a moment. But it has but in general, there is a category of left atrial reservoir strain, which is actually three categories: less than 18, 18 to 24, and then is 30 and above. I just showed you those parameters. Remember, they had actually in the normal function they had this reservoir strain 30 or more. Here they are 18, less than 18, more than 24, and between 18 and 24. Now, British Society of Echo is looking at reservoir strain as an important criterion and trying to define what is happening to these individuals, whether they have, along with impaired diastolic function, do they have elevated left atrial pressure? ASC doesn't do this thing. ASC just takes one criteria, that is left atrial reservoir strain less than 18 is one of the ways to identify diastolic dysfunction parameter and also the elevated left atrial pressure. In atrial fibrillation, the British Society of Echo actually did take in consideration something which is interesting. Now they had LA reservoir strain of less than 16. Remember, the ASC criteria which Dr. Singh presented did not have LA reservoir strain of in atrial fibrillation. They also have another interesting thing. The pulmonary venous S to D less than 1, not 0.67 as ASC suggested. They also brought in step 2 body mass index of more than 30, which wasn't present in the American Society of Echo 2025 criteria. And of course, they go like this, that of these, if the first 4, of course, are very similar, and you have already known the first 4, step 1 was similar. The problem was with step 2, which was very different from the ASC. And of course, as usual, in step 2, there are 3 parameters, more than 2 or more positive, it is impaired diastolic function. If actually more than two steps criteria negative, it is normal filling pressure. Now they had nuanced diastolic function assessment atrial fibrillation, unlike ASC, which had a different kind of approach. But remember, they also specified that the heart rate has to be less than 100 beats per minute, and they also suggest that ideally you should use an index beat method, which is actually a very close to what one would get in sinus rhythm. Okay, the British Society of Echo relied a lot upon age-specific E prime to define impaired diastolic function or grade 1 diastolic dysfunction. Now, for individuals who are above the age of 65, look at your extreme right. Mitral E prime, medial, less than 4 centimeter. Lateral E prime, less than 5 centimeter. But between 45 to 65, less than 5 and less than 6. Now, these criteria are different from what the American Society of Echo suggests. Between 18 to 40 years of age, the criteria suggested are exactly what they were in the ASC 2016, but regardless of age. And you need to keep that thing in mind. Now, the left atrial strain was more nuanced in British Society Echo guidelines, but they also had left atrial contractile strain shown at the bottom. And now you would note few things. These are the ranges. So we will just avoid talking about the ranges. But what was important was that the British Society of Echo said that above the age of 65 years, normal reservoir strain is between 24 to 56. If it is less than 24, it is abnormal. But 18 to 24 is border zone, less than 8 in sinus rhythm, and less than 16 in atrial fibrillation is of diagnostic importance. They also said that the normal pump strain is 9 to 30% in individual above the age of 65 years. And they also suggested 8 or less left atrial contractile strain is diagnostic of diastolic dysfunction and elevated filling pressure. Remember, those were the two major differences. So let us come to 2025 ASC update on diastole. Dr. Singh has taken you through all this thing. There is a revised classification of diastolic dysfunction, general population, in specific population, diagnosis of HFpEF, and of course, they do talk of AI in evaluating diastolic function. We aren't going to go through the detail, but they do acknowledge, like the British Society Echo, that age is an important determinant of all diastolic parameters, and so-called normal population may not have been normal. So they agree that whatever they have studied, what data they are relying on their data, may not have been completely normal population. And optimal values are different from normal value. That is another thing which they agree. And this the reason obviously is they already knew about the British Society of Echo guidelines, and British Society of Echo guidelines were more nuanced. So they actually said the 2025 guidelines were in step 1, look for impaired relaxation. Only rely on E prime and move forward if the E prime is less than 6 centimeter medial, less than 7 centimeter lateral, or average less than 6.5 centimeter or equal. In step 2, you look at all those 4 parameters which were there earlier, except the left atrial reservoir strain is 18 or equal or less than 18. Now, here is a slight difference. The British Society Echo says less than 18. This says equal or less than 18. So there is a minor difference. Now, the step 3 is how certain you are of diastolic dysfunction. It says if the E prime is reduced, age specific, then only one parameter out of these 4 given in step 2 is good enough to diagnose that diastolic dysfunction is present. But in case the E prime is preserved in more than 6 or 7, then you need 2 parameters for step 2 to diagnose diastolic dysfunction. And I will, when I present cases, we'll discuss this issue in much greater detail. They also had the impaired LV relaxation based for E prime, and they chose 6 and 7, largely for above 65 years age, but even for 40 to 65 years, the same criteria can be applied. That is exactly what they did. They also had actually left it a reservoir strain, but they mentioned something which British Society Echo did not mention. That is, The two methods, the EchoPaco G and TomTech, give little different values. TomTech gives a higher left atrial reservoir strain. This is what you need to keep in mind. And this has already been discussed by Dr. Singh. I wouldn't go in those details. Essentially, you have brought in actually a criteria of left atrial reservoir strain equal or more than 18, and alternately IVRT 70 millisecond or less, which wasn't there in 2016 guidelines. That is all the difference. And in atrial fibrillation, they brought in actually the here again they have brought in the body mass index more than 30 kg, but the pulmonary vein to SDG ratio less than 1. So that is okay. That pretty much is all right. And we do understand that in MAC, they, as Dr. Singh showed, they have brought in IVRT as a criteria. Less than 80 millisecond indicates increased left atrial pressure, those who are E2A ratio more than 1.8. And this is how in pulmonary hypertension they measure. We will not go in that detail. But let me summarize. And we will actually discuss all these things in much greater detail when we present cases to you. So in summary, there is a lot of similarities between various guidelines. There is increasing importance of stress diastology, which we did not discuss this time because we did not have time. In 1 hour, we can't discuss everything. There is a lot of importance to left atrial strain. ASC 2025 guidelines don't mention LA contractile strain. Why? The LA reservoir strain has been taken only one value, 18 or less, while the British Society guidelines have different sets of criteria for left atrial reservoir strain and left atrial contractile strain. There is a slightly different approach for atrial fibrillation. And of course, as we know, validation needed in a prospective study for ASC 2025, although Dr. Singh did show a study of 940 odd patients showing good sensitivity and specificity, new guidelines compared to old. But they did show that they have improved the sensitivity by 10% without affecting the specificity. I have my own doubts when these will be applied to different parts of the world. Thank you very much.
Thank you, sir. I think we have good questions, and maybe we would invite those people to actually um, unmute them, and then they can ask the questions themselves. Uh, Dr. Hamid wanted to ask a couple of questions from me, and then your presentation. Dr. Hamid would go ahead.
Yes, sir. It was a nice presentations till
Mhm.
now. My question is that there are different initiating points between the BSc and the ASC guidelines. The E dash has been relegated to a secondary position. Why is this so? Secondly, LAVI has been really bashed in the ASC guidelines, whereas it has been given prime importance in the BSc guidelines. And LAVI, as we know, can happen enlarged left atrial volume index even without diastolic function, diastolic dysfunction. And thirdly, the range of LAVI, that bothers me. In the table they have given, the range has gone up to 41 milliliter, whereas the cutoff value is just less than 34. So how to accommodate this discrepancy? Thank you, sir.
Yeah, Dr. JC, please.
Yeah, so let us start with the last question.
Hmm.
The new range is based upon focus LA volume, focus LA views for the volume.
Hmm.
The previous studies were not LA focus volume. Now, when they have looked at the LA focus volumes, obviously the volume goes up by about 6 ml per meter square. Remember, we also published something on LA volumes, and we were surprised that our LA volume was small because none of us did that study of focus LA volume. With regard to LAVI being given less importance by ASC compared to ESC is based upon the work which Yogesh Reddy and Barry Burlock published in 2021. And since it is a Mayo data and the guidelines are largely Mayo guidelines, basically.
Hmm.
And they said that the left atrial volume index as a criteria for diastolic dysfunction has a sensitivity of only 37%. That is why the ASC has tried to give a little less importance to left atrial volume index in their newer guidelines. The E prime, the third part was about the E prime, that is to initiate the whole issue of um, uh, whole issue of starting the diastolic with E prime is a pretty good idea. However, the issue is they have taken 6 and 7 median lateral and average 6.5. My point is that in elderly individuals, especially in South Asians, these criteria would actually fall flat. We would have many more people who are perfectly healthy and have a 4 and 5 because Roxy Senior's work has shown that we Indians could have up to 1 centimeter per second less E prime and S prime and A prime. So my guess is that they focused a lot on this, the E prime to initiate the whether diastolic dysfunction present, but this is going to be the weakest link in these guidelines.
So I think
Yes.
during these guidelines also they did mention, put up a note that we are not taking LA volume as a major thing because LA volumes do not follow, the remodeling of left atrium doesn't follow very nicely the diastolic dysfunction while the strain does. And there are other many conditions where the volumes can be increased, anemia, any hyperdynamic circulation. So they didn't mention that we are not taking this because of that.
Yeah, but there is another thing. When Barry Burlog actually published a study on HFpEF, where catheterization was done in each and every case, they found that 70% of people had left atrial volume less than 34 ml per meter square.
Yes.
So
And
I
the
just
thing,
wanted to
go ahead.
ask one thing, and I mean say that if we look at the new ASC guidelines, they've kept the LA volume index as a second rung rather than the first. In first, they just taken the Doppler parameters and PA pressures. British guidelines, on the other hand, take LAVI at the top, and that's how they go forward. I think it's also a practical consideration because LAVI can still be calculated by most people, while strain is still developing in a development phase. Not everybody would be having strain or how to do strain at the present moment. So probably British guidelines will help the masses a little better as compared to what the ASC is doing right now. Not sure, but so your comments.
I do agree on those comments, but the BSc actually has very interesting data. For AF, less than 16% left atrial reservoir strain. For ejection fraction less than 50%, 18%. For normal, three categories, less than 18, less than 18 to 24, more than 24. And then the left atrial contractile strain of 14 or more, considering normal filling pressure, because 92% patients they mentioned have normal filling pressure. And 8 or less percent, which 90% people have elevated filling pressure. 8 to 14, of course, is the mid range. So the very interesting thing, the only difficulty with all that thing is we also realize both LA volumes are time consuming. You have to do it biplane. And in case you are trying to use a biplane method of Phillips, the focus view, when you get off the four chamber, you don't get focus view of the two chamber. That is the major difficulty. And in a similar way, the other difficulty comes left atrial reservoir strain. The difficulty, the ESC says one view is enough, four chamber view is enough. The Americans say two view and average the two view. And they again say that you have to actually have a focus view, which of course means that you have to elevate the transducer anteriorly slightly and of course go slightly more medially to get the left atrial volume. Having said that, you would have to train a lot more people to get focus view. And that is why the reservoir strain is still more easy to calculate because no study has shown that the reservoir strain would differ in case it is a focus or non-focus LA volume. But the volumes would definitely differ a lot.
Mm. And we know that the both G and Phillips will have different values. I mean the tracking is very different.
Dr. Singh, I want to add one
Yeah.
comment that from now onwards, we have to mention which guideline we are adopting in our reports while reporting for diastolic function, either British or American. I think we should reference them in each and every report. How do you take that?
I think, sir, I think you answered that. I don't think so that we are going to mention. We would probably mention the parameters and give a suggestion that, okay, this is what the parameters are, and this is my impression. Rather than saying I'm following this guideline, I don't think so. I would be writing that.
Yeah, I agree with you. It is easy to say it is grade 1 and grade 3, largely that that the big group of so-called grade 2 we would say, well, these are the findings. These suggest that there is diastolic dysfunction present, and the filling pressure is likely to be elevated. That is what I would write.
Yeah, we would write probability only and then maybe. So I think there is one more question, I think that Dr. Vishwajit Majumdar wants to ask. You are unmuted. Can you ask?
Okay, I'm Dr. Bishir Mundar. Nowadays, there is interest on isolated atrial cardiomyopathy or atrial cardiomyopathy. So I think LA reservoir strain will be useful. Is there any recommendation or any literature regarding what are the other parameters may be useful in isolated left atrial cardiomyopathy?
So we'll discuss this issue when we present cases. We have a very interesting case, exactly what you are talking about.
Okay,
We will discuss that issue in great detail.
Okay, thank you.
And Dr. Qureshi had a question. Dr. Qureshi raised his hand.
All right. 1 minute. Okay. Okay. Yes, Dr. Qureshi.
I only have a suggestion. I think it is very important that we do not get into the dilemma of whether it is the British Society of Echocardiography that we are following or the American Society. We just follow one system, and instead of making things more complicated, I agree with Dr. C Mohan that once we find that there is diastolic dysfunction, we find out if there is a raised left ventricular filling pressure, and that is what we should be reporting.
Right.
So I think, sir, we can go ahead with the cases.
Yeah, absolutely.
So, how are we beginning? What is the sequence? Sir, are you presenting first and then Dr. Vinayak?
Whatever way you want.
No, this is between you.
You are the organizer. You decide, actually. I have absolutely no problem with that.
No, I think maybe we can alternate. Is that okay, Vinayak?
Yeah, absolutely.
All right. Sir, you always begin. You begin the case, and then Dr. Vinayak would alternate with you.
Let's go ahead. I'll present after them. No problem.
Okay. So I will present one case, then Dr. Vinayak, and then another case, right? Okay.
All right, sir.
So let's get going. So diastology cases. This is case 1. This is a 70 years male with a body surface area of 1.6, weight 55 kg. He is on a dual chamber pacemaker for 6 sinus syndrome, and I believe it was a wrong indication. Repeatedly, we have seen this patient neither sensing and not pacing at all. When a Holter also, there is 100% sensing, no pacing at all. So he also had LAD and RCA PTC in the past, but the stents are patent. HbA1c of 6.5. He was never diagnosed diabetic, but HbA1c 6.5. BNP 54 picogram per ml. Blood pressure 112/67 and PR 60. But he has a class 2B dyspnea. He's significantly dyspneic. He walks about 100 yards and gets dyspneic. And that is at a leisure pace, not fast. And sometimes he gets dyspneic on household chores also, especially when they involve going by flight of stairs. So he was evaluated, and we did a parasternal long axis and 4-chamber view. As we would note, the left ventricle is normal size, left atrial is normal in size, mitral and aortic valves are normal. The 4-chamber view shows you slightly dilated left atrium, but dilated right atrium. That could be because there are leads, actually, the atrial and ventricular lead in the right atrium, but we'll discuss that point. But you can clearly see that the left ventricle function is normal. And of course, right ventricle function also on face of it looks all right. We will quickly just look at a four-chamber strain, and the reason is Tom Marwick's data Sukur study says that four-chamber is good enough for day-to-day purposes. It correlates extremely well with the overall the bullseye global longitudinal strain. So the global strain is minus 17.6. We'll call it lower limit of normal, ejection fraction 61%, and peak strain dispersion of 35 milliseconds. We are reasonably all right, actually. You can look at this graph on your right side, and you would say, okay, this train looks pretty much all right. We are also aware of the fact that at this age, the guy may have a 17.6, which is okay. Okay, so the left atrial volume by biplane Simpson method was 26 ml per meter square, which actually would be called a normal left atrial volume. And LV function, it looks good. So the ASC 2025 guidelines, step 1, look for impaired relaxation, E prime. So let us look for impaired relaxation. E prime medial is 7 centimeter, E prime lateral is 9 centimeter. So the first step of ASC, well, the E prime is preserved. Go to step 2. We go to step 2 and we have to look at 4 parameters. E to E prime more than 14, EA ratio of between 0.8 and 2, and levy of more than 34, and left atrial reservoir strain of 18 or less. Let us look at step 2. Step 2, E to A ratio is 1.9. Actually, the common sense dictates that at 68 years of age or 70 years of age, 1.9 will always be abnormal. But the AC says don't take it like that. Okay, so the one parameter is abnormal, that is E to A ratio. I tried hard and I'm just trying to show you that, you can see some trace TR, you can't measure velocity. I mean, I can see that even if I look at the traces first 4 beats, I can't find out the bottom of the spectrum. So I don't know what is the velocity. And this is true for most of the patients whom we are assessing. So TR is not there. The second criteria is not full. What about on left atrial volume? I have already shown you. So we don't have we have E to A ratio between 0.9 to 2. We don't have TR, and we don't have left atrial volume more than 30. So only thing we have to now rely to get 2 parameters besides the preserved E is left atrial reservoir strain. But we'll talk about that. What about E to E prime ratio? E to E prime actually medial is 14.2. It has to be 15 or more. Lateral is 9. So the average comes to about let's say 12 or 11.5. So it doesn't fit with that criteria of E to E prime of more than 14. More than 14 is not fitting average. So we are not having E to E prime criteria. We are not having left atrial volume criteria. We don't have TR velocity. Okay. Now we go to the left atrial volume. The left atrial reservoir strain. And here is the left atrial reservoir strain. It is 15%. That fits in the criteria, 18 or less ASC criteria. So now you have 2 criteria with preserved ejection. One, E to A ratio of between 0.8 to 2, and then left atrial reservoir strain of 15%. If you go by the British guidelines, the contractile strain is also -7. That also fits in. So another view, just to show left atrial reservoir strain, now it is 16%. But the contractile strain is -9. So we don't, if you go by ASC, the reservoir strain is good enough, 16%. Okay. So we have now 2 criteria. We in the step 2 criteria, we have got 2 criteria of step 2, EA between 0.8 to 2, and the left atrial reservoir strain of 18 or less. We also looked at the RA reservoir strain, although it is not in the guidelines, but it was also significantly reduced, 10%. Again, another beat, 10%. And of course, inferior vena cava dilated. Obviously, this patient is in heart failure, right? Inferior vena cava not collapsing, it is dilated, and the left atrial reservoir strain is decreased. So the patient has elevated filling pressures on both right and left side. Right side, there was no confusion. The left atrial side confusion was E to E prime was just 11.5. There was no TR for us. LA volume was not increased. So we did not know whether this is a predominantly, looking at the images, we did not know whether it was predominantly right heart disease or it is actually HFpEF causing for me the right heart disease. So the right atrial reservoir strain has a modest sensitivity and specificity less than 15%. That is beside the point. But much more important is left atrial reservoir strain of 16 or less has a wedge pressure at rest of 15 millimeter. Our patient had left atrial reservoir strain of 15 and 16. So we believe that at rest is wedge pressure more than 15. And that is the criteria to diagnose heart failure with preserved ejection fraction. We also know that up to 40% patients don't have the filling pressure increase at rest, and they may need stress diastology or looking at left atrial reservoir strain as was seen in our patient. We went beyond the mandate given by the guidelines, but the guidelines do talking about left atrial stiffness index, which is E to E prime ratio divided by left atrial reservoir strain, normal being less than 0.27. Our left atrial stiffness index is 0.8, clearly indicating disease is in the left atrium. Primarily, it is a disease of the left atrium with reduced left atrial reservoir strain, reduced left atrial contractile strain, increased left atrial stiffness, and that is why the patient is symptomatic with HFpEF. What about the left atrial stiffness and prognosis? Here is a study of 2023 showing you that left atrial stiffness actually, when increased, is a marker of all-cause hospitalization for heart failure and mortality. The Korean study showing you a huge difference, very, very significant difference. And the stiff left atrium has limited capacity using Frank-Starling mechanism, so the filling pressures are elevated. So our patient has unique HFpEF with early involvement of atria. This patient did not have TR velocity. E to E was not above 14. LA volumes were normal. Left atrial reservoir strain came to our rescue. And we do agree with the observations of Dr. O and colleague that ASC 2025 guidelines provide better sensitivity because these have included left atrial reservoir strain, which improves the sensitivity of detecting HFpEF and detecting elevated filling pressure by at least 15 to 20%. And I will stop here, present second case later on. Discussion on that.
Dr. C Mohan, this is Dr. Qureshi from Pakistan.
Yes,
Your case is excellent. There are 2 points which I want you to clarify. Number one, you said that the longitudinal strain in the 4-chamber view is good enough. You don't need, and that actually brings, especially me to the rescue, because normally what I find is that the 4-chamber view is very well taken, but the 2-chamber and the 3-chamber view becomes a little difficult, and that is where you have the discrepancy. So that's a good idea that you only use the 4-chamber view. The other thing is that, for example, in my machine, we don't have the left atrial strain. Can I use the LV strain upside down to measure the LA strain reservoir?
Dr. Qureshi, I agree with your both comments. You can use the LV strain algorithm for left atrial strain. Most machines will accept it. And these would give you values which you can interpret correctly. With regard to the 4-chamber strain being a surrogate for bullseye 3 view strain, I was relying on the data of Sakur study by Tom Marwick and colleagues of 600 odd patients, cancer patients who were being given anthracycline therapy. They did look at the 4-chamber strain alone versus the composite 3-view strain, and the R value of between the two was 0.85, and the limits of bias were only 2%. Limits of bias were 2%, which is acceptable, because even if you and me do on the same four-chamber view, we can create 2% difference. So that is why ever since that study came to my mind, quite often when I'm in a hurry, I just take the four-chamber strain.
Can you just post the study that you are referring to?
Succour study, SUCCOUR, Succour study. This is Dr. Tom Marwick study. You will be able to Google it.
SUCCOUR.
SUCCOUR, Succour study.
Okay. Thank you so much. Thank you so much.
Dr. Imran Hamid again from Pakistan.
Yes,
Dr.
Dr.
Singh
Imran.
has rightly started his presentation with the algorithm 2. And
Yeah.
if we use just the algorithm 2 of the ASE guidelines, skipping the algorithm 1, I think
Yeah.
that will save time and will reach the same conclusion. Do you agree?
I would agree, but actually the guideline says use step 1 first, then step 2, then step 3.
Yeah.
So in our case, you are right that step 2 would have been a right way to go about. But I was just showing you the fallacies of ASC 2025 guidelines.
That's right.
My point to you was that I actually would have, I believe in Dr. Roberto Lang's paper, which he published in 2020. He says, forget about the entire algorithm. If you do a very good left atrial reservoir strain, that is good enough to diagnose most of the diastolic problems. Now, that is a big statement, and that is a huge statement. You may not agree to that, but the first author is Dr. A. Singh of that paper. It's published in, I think, in Circ Cardiovascular Imaging. But it's a great feeling. He says, forget about all the algorithm. Just look at the left atrial reservoir strain, and you'll get all the data you are looking for.
I agree.
You would get diastolic dysfunction, and you'll get elevated filling pressure.
Yeah, I agree with this. And if you can add just E dash and E over E prime, along with Lars, that is left atrial reservoir strain, just these three parameters, I think that will make things a bit easier to comprehend and to apply clinically.
Yes, I am in agreement with you. Thank you both to Dr. Qureshi and Dr. Hamid. We just have a request to you. We do a monthly meeting on very interesting echo cases called Echo Delhi. Why don't you join that actually every month? Actually, we do on first Wednesday of every month, but we do at 9 p.m., 9 to 10 p.m. Me and Dr. Vinayak, you should join. Actually, we would actually be really we will become wise by your interactions.
Thank you very much. Please send the
I think
link. We'll surely
Jesse
join.
Mohan,
We'll
you
send the
have
link.
you have my email, so you can actually send me the invitation.
All right.
And
I
I'll
would.
contact
I think I would do that. I'm in your group, so I'll do it in a WhatsApp.
Thank you.
Thank you so much. Thank you so much.
So I think
Dr. Vinayak, yeah.
I'll just present one case. And in fact, more than presentation, I would like our our panelists to actually, esteemed panelists, to comment on that as well. So this is, continue to share. Okay. Now this is a 18-year-old male, actually 17 and a half, 45 kgs, BMI of 23, presented to our emergency in acute decompensated heart failure with severe LV dysfunction with atrial fibrillation. Now this is his echo, which you can clearly see that there is severe LV dysfunction. Ejection fraction is hardly 15%. There is mild to moderate regurgitation. All four chambers are dilated. And this is different views. You can see the RV focused view as well. You can see that there is mild to moderate tricuspid regurgitation, and CVP is somewhere around 8 mmHg. And this was the heart model with Phillips. So you can see that it's a little blurred, but the ejection fraction was quite low, around 15%. The end-diastolic mass was around 136 grams. The BSC of this gentleman was just 1.5 meters square, and the overall you can say larvae was quite large. The larvae was nearly more than 100 ml per meter square. We also did his RV function, and you can see that various parameters of RV function. TAPSE was just 8.5 millimeters. The FAC was 18% severely reduced. The ejection fraction was also markedly reduced to just about 16%. This is the RVEF that we're talking about. And if you look at the right ventricular free wall strain, it was severely reduced to just 12%. Going further, as expected, the ejection fraction was very, very low, and so was the global longitudinal strain of just minus 7.7%. The average was around minus 6.3%. So 4-chamber was 7.7, the average was minus 6% only. So when we did the so obviously this patient was in atrial fibrillation, so there was no A wave. And you can see a very tall E wave of around 140 centimeters per second. And the other wave which you see is the L wave, which Dr. UP had already shown you. And look at the E prime. E prime was actually significantly low at around 5.8 centimeter per second. And this is a young man that we're talking about, 18 years of age. And the lateral wall was also 10 centimeter per second. Now here I want to tell you that when we talk about atrial fibrillation, we're not averaging the septal and the lateral wall. We're just taking the septal E prime when we are calculating the E upon E prime ratio. The TR velocity was more than 2.8, so it was 3.3 with a PA pressure of systolic pressure of 44 millimeter. The averaged out was around 44 millimeter of mercury. So if I take the estimation by the 2024-2025 ASC guidelines, you're looking at the mitral E more than 100, which is more than 100, so it's 140. The septal E upon E prime was more than 14, so which is 23, more than 11, which is 23. In a normal patient, we take it as 14, but here we take the cutoff as 11. The TR velocity was more than 2.5. I did not take the DT. Now here, why I'm saying this is that normally we don't take DT, as part of the guidelines because they were eliminated from the previous guidelines. And all that I would say is that we should get into the habit of taking DT on mitral inflow in all the cases wherever applicable, especially in patients of atrial fibrillation. Moving forward, so if I go by the algorithm, we know that the 3 out of 4 were positive, and hence clearly the patient has elevated left atrial pressure. But please remember that this is a case of severe LV dysfunction with AF. So I don't need to go further, but then let's still go and check out these Lars, pulmonary vein, etc. So BMI was less than 30. Let's check out the left atrial reservoir strain, and you can see it was markedly reduced to just 5.7%, and even the the contractile strain was just 2%, extremely low. Look at the diastolic pulmonary vein flow. The DT of the pulmonary vein diastolic DT was less than 220 seconds. It was just 146 milliseconds, which also evidence towards increased left atrial pressures. So here we are, the positive findings in this case. If you look at the DT was actually of the mitral was pretty steep, so it would be less than 160. I haven't calculated it, but it is pretty evident by itself. So 4, and then you have the Lars, which is reduced pulmonary vein systolic to diastolic flow is definitely less than 1. We can hardly see the systolic wave. And the BMI is the only thing which is missing, which is less than 30. So this is what we have already mentioned in terms of AF. If you have a standalone L wave, here it is almost 40, but anything which is more than 20 centimeter per second will be considered significant. You can also see the L prime wave on the tissue Doppler velocities. So when we talk about left atrial pressure and AF, we have to remember that there is no single parameter which has a very strong association. Most of them together will have a moderate accuracy. One should always average values from several cardiac cycles, at least 5 to 10 cardiac cycles, and select cardiac cycles selected cardiac cycles should be reflective of the average heart rate. So I think that is the take-home message is that in AF, the index beat method can be used, which Dr. C Mohan had already said. So I just thought I'll present this interesting case. Thank you.
So very nice. I think Dr. JC, do you want to add anything? And then it's next
No,
your.
it's a good case, but my only point is that sometimes we don't have to do so many things. Somebody who has ejection fraction 15-20%, I know the guy has a LA pressure which is elevated. I know that patient has LA diastolic dysfunction. I do these have independent prognostic significance? Yes. So for diagnosis, I don't need these parameters.
Agreed.
Left atrial reservoir strain has prognostic importance. That is true. Why want to see whether reverse remodeling is occurring? The last bulwark is LA strain. If the LA strain starts improving, I know patient is improving. The third importance is similarly deceleration time. As the deceleration time prolongs, patient is getting better. If the deceleration time is getting shorter or is remained same, patient is not improving. So some of those points are more prognostic than diagnostic. So in AF, I think those have they have a lot of prognostic value. Similarly, the other thing which we discussed about in this particular patient, the atrial fibrillation part, the E being more than 100 mostly it is above 100 centimeters. Mostly, that's what it says. So I don't think that adds much to it. But nevertheless, I think for prognosis, each of these independent parameters of great importance. The left atrial reservoir strain with correlated with VO2 max. With also, I mean, if you don't want to do VO2 max and you want to decide this patient should go for heart transplantation for whatever reasons, looking at that left atrial reservoir strain of 5, I would say, yeah, I don't need any other parameter. This patient, if it doesn't improve on therapy, is a candidate for heart transplantation.
So actually, we sent him for heart transplant eventually. But the idea was just to show, like all the parameters in one patient. I think we were lucky to get.
Absolutely.
How frequently are you having transplant done in India?
So I think there is a sort of a north-south divide. South is doing quite a lot. North is also doing significant numbers. But overall, I think India is doing quite a fair number of transplants per year. I'm not sure about the numbers per year, but somewhere around, I think 500 or so. I'm not sure. So
500 per annum?
I think, yeah, per annum.
And it is possible to get the donors easily, the donor heart.
So the awareness is increasing, and I think we are finding every year we're finding the number of people who are ready to donate is increasing. The awareness is also increasing. So I think eventually, probably in the next few years, we'll have much more donors as compared to what we have today.
I'll just chip in. But there is a definite north-south divide. The two centers in South India do about 100 cases each. One is led by Dr. T. Sundar in Apollo Hospital, Chennai. Another Dr. Balakrishnan, who is in Kovai Medical Center, if I'm not mistaken, Fortis Kovai Medical Center. They do about 100 a year, each of them. And the Tamil Nadu has the most generous policy with regard to organ transplant. And the government helps a lot. And in case there is a person from outside also, and the person is willing to stay in Chennai for 2 months or more, there is a good chance that the heart would be given. The other center, pardon?
There was a time when we had a lot of people from Pakistan going to India for liver transplant.
Yes.
And then probably things declined. I would really want that if there are a number of patients who are with end-stage heart failure, and if there's a possibility, I think it would be very good if we can send them over to India and they can have their heart transplant. How much would it cost there?
Let us talk in terms of US dollars. And typically, a heart transplant in India would cost something like $70,000. Liver transplant also costs the same, about $70,000, even less also. But considering that you have to arrange other things, logistics and everything, maybe $70,000.
Dr. Hamid?
Yeah, just one comment, Dr. Agrawal, very nice presentation. That has been mentioned on the issue of one beat or multiple beats averaged, that if the average distance between the RR interval is less than 100 millisecond, you can take just one beat. That has been mentioned in the BAC guidelines.
I thought it was 60. I'm not sure if it is 100 in BSc.
Yeah, I remember it's 100. Maybe we can check it up.
Because the index beat method we usually take as a 60, but I think that's fine. Fair enough. Sure.
Sir, Dr. JC, please, I think you share your screen and.
Okay. So we have, let me bring in the second case and then quickly try to wrap it up. Okay, we were here. Okay, this is the second case. Okay, so this is the second case. This gentleman is a 74 years old physician. And the interesting part is that there is a 5-generation connect with this physician. His grandfather and my grandfather were friends. His father and my father were friends. He and me are friends. His children and my children are friends. The only problem is his grandchildren now live in UK and they don't have any connect with my grandchildren. But it's an interesting story. So he has type 2 diabetes for 20 years, body mass index 35, he's heavy. He had a PCI of LAD in 2007, asymptomatic, and he says he has a good effort tolerance. This is self-reported. We have not done any CPAT study. ECG nearly normal, HbA1c 8%, LDL 20 milligram. He is on statin and inclisiran. So he just wanted an echo from me. You know, asymptomatic guy walks in the clinic, says, can you do an echo on me? I said, sure, we'll do an echo and there's no problem. So we did an echo. His wall thickness is 12 millimeter. The interventricular septal thickness 12. The posterior wall was 11 millimeter. So borderline. Pericardial fat you can see at the top. Left atrium when parasternal long axis view size was 35 and there is no mitral regurgitation. 4-chamber view. Now that is the LV function is reasonably good. When I was looking at actually the 2-chamber view, I do see that the apex is not that good contraction, but we will, for the moment, we'll forget about left atrial volume is 22 ml per meter square. Now the left atrium does not seem to increase in size, and this is as best focus view as I could get. And you have a 4-chamber view as well as a 2-chamber view. All right. No TR and no MR. Now that was another thing, no TR and no mitral regurgitation. So the first step, I want to do diastole. The first step, ASC, look for E prime and medial lateral. He just, that says less than 6 and less than 7. He has 6 and 7. So let us call it borderline. The lateral one is 7 centimeters per second. The medial one is 6 centimeters. He just sits on that. We have to go to step 2 to get one more parameter out of those 4 parameters. But we already know there is no TR, will not get TR velocity. We already know LA volume is not there. What are we trying to get? We are trying to get the E to A ratio, and of course, we'll look at for the left atrial reservoir spray. Now, we have already talked about the E to A. Now, he is about 65 years of age. And the British Society has put 4 and 5. So he, according to the British guidelines, he has a normal medial E prime and lateral E prime. Because 4 and 5, and he has, of course, 6 and 7. But according to American guideline, he just sits on the border. This is a transmitral flow pattern. So the ratio is actually 1. So, so we are pretty certain that 1 fits with that 0.9 to 2 ratio. It is not 1 exactly, 1.08 the ratio. 1.06, the upper column shows you here. The deceleration time is 193 millisecond. All right. Issue actually is that we have got one criteria and we have E2 E prime, which is borderline. What about E2 E prime? The medial E2 prime 13.5, it should be more than 15 to be called abnormal. And the lateral is 13, just again sitting on that border. And the average would be, of course, 13.25. We are just sitting on the border and everything. And the RV function, the S prime is all right. It's about, if you take S1 and S2, if you take S2, it is significantly reduced. If you take S1, it is significantly better. So here is the confusion actually. People say take S2. The S2 is just 6 centimeters per second. So does he have RV dysfunction? I don't know, in fact, to be honest. And the E prime is also actually 6 centimeters. I would presume that there is RV dysfunction. But I will leave it to for you to think over that. The global longitudinal strain is significantly reduced, minus 11.7. Ejection fraction turned out to be 47%, although visually it was looking better. But then who can argue against complete automation? It is complete, fully automatic evaluation of global longitudinal strain and of course the ejection fraction. And I would believe that this is correct. This is what the values are. So we did not have TR, but so the interesting part is that the global longitudinal strain is still a criteria in HFpEF, but is not a criteria for diagnosing diastolic dysfunction or raised left atrial pressure, although it is significantly reduced at 11.7. We looked at left atrial reservoir strain, and you have 4-chamber and 2-chamber view, and the average is 12%. Look at the biplane bottom, 12%. 4-chamber, it is 12%. 2-chamber, it is 12%, and average is 12%. With regard to contractile strain, it is -4 and -4. Very similar. So we have a peak atrial longitudinal strain or left atrial reservoir strain of 12%, contractile strain of -4%, left atrial volume of 22, again telling you that the left atrium may not dilate. It doesn't dilate in 70% cases of raised left atrial pressure. E2 prime is 13, sitting on the border. More than 14 is what is required, and there's no TR. Now he says he's asymptomatic. And of course, we have diagnosed that he has diastolic dysfunction, and it is most likely grade 2 diastolic dysfunction. Why? Because the E to A is between 0.9 to 2. So he has a grade 2 diastolic dysfunction, asymptomatic. But what bothers us actually is the left atrial reservoir strain, extremely low, and contractile strain extremely low. I was referring to this study in Journal of Cardiovascular Imaging, actually by Roberto Lang. He says, can a single parameter replace the algorithm of diastolic dysfunction? And would that be LA reservoir strain? And answer is yes. If it is less than 16% sinus rhythm and measured correctly, it probably can replace. Our patient has less than 12%, and contractile strain is -4%. Although Dr. Roberto Lang's paper doesn't talk of contractile strain, nevertheless, our patient has very, very bad left atrium. Although left atrium is not dilated, but its mechanical function is severely impaired, and he claims to be asymptomatic. One can put it on CPAT. I'm pretty sure that this would not be the case. He wouldn't be asymptomatic. He has grade 2 diastolic dysfunction, and prognostically, a left atrial reservoir strain of 12% is not a good thing for this gentleman. So that is all I wanted to show. Today, I was focusing on left atrial reservoir strain rather than anything else, and I thought even asymptomatic individuals, diastolic, so he is a grade 2, and he also has, of course, very poor prognosis because left atrial reservoir strain of being 12% and even left ventricle reservoir, the left ventricle global strain is -11.7. So surprisingly, LAV and LA strain are similar directions. Normally, the ratio is actually 2 to 1. Left atrial reservoir strain is twice of ventricular longitudinal strain. So this is a very interesting thing, and we call it dissociation of longitudinal strains. Dissociation of atrioventricular longitudinal strain, an important marker of prognosis.
Dr. Mohan, your patient has an apical hypokinesis also. This is from his previous, probably, MI, because he had been stented in the LAD and in the RCA, or maybe it was a circumflex. So probably, and then maybe he's also been exercising regularly, which would end up in his not having any symptoms, because it is more or less a rehabilitated heart that he has. So probably that is the reason why he's asymptomatic, but because of his LA reservoir, as you have mentioned, is very low. That may, because here then you'll have the left atrial myopathy, which you can he will develop, and that is why the prognosis is not good in this patient. Would you agree to that?
Yeah, I would agree to that. There is definitely apical hypokinesis. I think it is as a result of the LAD disease. The other segments look, the ejection fraction, actually the ejection fraction visually was looking all right, but by the automatic method, it was 46%, 47%. Global longitudinal has significantly reduced. That is because of multiple reasons: diabetes and coronary artery disease. Obesity is playing a role. We know obesity also decreases the global left ventricle strain as well as left atrial reservoir strain. But overall, I was just trying to say that you can diagnose, despite an E2 E prime sitting on the border, TR being not there, E prime sitting on the border, you can tell that clear cut this is a grade 2 diastolic dysfunction, and that his prognosis is not good, because even in a grade 2 person, the left atrial reservoir strain can be 23, 24 also. And these people will have relatively better prognosis. So within that grade 2 diastolic dysfunction, you can actually categorize these people as not so bad and really bad. I mean, 12% is really, really bad strain. We understand that there are, I did not show you the whole spectrum. I have hundreds of cases of different variety, but then Dr. Singh said, stick to the time, and I thought I'll present to you short cases of diastasis.
But my question,
His prognosis appears to be not so good because of his obesity.
Yeah.
Dr. Hamid, just
Yes, sir. I will corroborate your case with the LV dysfunction. We have got normal LV ejection fraction, but we get reduced strain. We call that as subclinical LV dysfunction. Can we label your case, because we are getting only strain parameter as abnormal, as a subclinical LA diastolic dysfunction, or subclinical diastolic dysfunction? Because LA is the first thing that is picking it up, and the years to come, this patient may have abnormally other parameters also.
LVF was 47, right?
Yeah.
Not exactly the LV. I'm talking just about LA.
LA.
That for diastolic function, we are getting just one parameter abnormal. So in the years to come, he may have other parameters like LA enlargement and EA ratio, E or E prime ratio, and reduced E prime as well. You're picking your case very early on for diastolic function only.
Because of your E and E prime sitting on the border, I think what you would say is that this is a borderline normal filling pressure, because just a little bit on the other side would be raised filling pressures. And
but I
probably
think that these parameters will raise concern to keep this patient under close follow-up for future this diastolic dysfunction.
But I think we need to take you to this. We need to take you through this study again. If the left atrial reservoir strain is less than 16, what happened? I was sharing the screen. Something happened, right? No.
We could see it, sir. We could see it.
No. I will go back. Actually, I just wanted to show this. The wedge pressure in his case is more than 15 in all likelihood, because the left atrial reservoir strain less than 16%. We are talking about of resting this thing. So we know that he has elevated filling pressure. He's not having that kind of normal LA pressure. What are the chances actually? The chances are pretty high that his resting wedge pressure is more than 15. Actually, it has been suggested that below 16 there is a good over about 90 to 92% chance that the filling pressure is elevated. So I wouldn't call it normal or near normal filling pressure.
That's what my point was, that we should not dismiss this case as entirely normal.
Yes, yes, absolutely, absolutely.
Dr. Mohan, did
For the
you do the
sake of the time,
antifobial
sir, I
field
think
session?
for the sake of the time, let's move on because we're already overshot by an hour. So I think I will request Dr. Vinayak to present his last case, and I would not present any because for the sake of the time. But I think I like because there's a good discussion. We've learned a lot. That's more important than just the time. Am I right, sir?
Yeah, absolutely.
Absolutely.
So my case is very short, less than 5 minutes, because it's just a representative case of an HCM, hypertrophic cardiomyopathy, in a 57-year-old male with no significant past history of hypertension, diabetes, or CAD. Now, before I show the case, we must know that diastolic function in HCM, the impaired LV relaxation is an early finding even in patients who are carriers of pathogenic HCM mutations and can occur much before the development of physiological hypertrophy or phenotypical left ventricular hypertrophy. So restrictive LV filling with increased E by E prime is directly linked with reduced functional capacity, hospitalization for heart failure, and sudden cardiac death. Now, one of the things which we see most commonly with HCM, especially the obstructive variety, is significant mitral regurgitation, which itself can lead to elevated LA pressures, LA volumes, peak TR velocity with decrease in the pulmonary vein systolic to diastolic velocity ratios. So it can confound the diastolic function. However, MR does not affect the pulmonary vein AR velocity, the atrial reversal velocity, and AR peak velocity and duration can be used for LV and diastolic pressure estimation in these patients of HCM in the absence of first degree AV block and atrial cardiomyopathies. So with that background, when we look at the HCM cases, with the way we address the left ventricular filling pressure is based on four parameters: average E upon E prime more than 14, AR minus A 30 milliseconds or more, peak TR velocity more than 2.8, and LAVI more than 34. So we are pretty much looking at the AR minus A as one of the most important parameters in cases of HCM. The rest three anyway we calculate in everyone. So this is a classical case of hypertrophic cardiomyopathy. This patient also had significant mitral regurgitation and an LVOT gradients of around 42 at rest. And this was his parameters. The Doppler E upon A was 1.1, and you can see that the DT was around, deceleration time was around 195 milliseconds. Here, the medial E prime was extremely low at 2.8 centimeter per second, and the lateral was also significantly low at 4.3. So the average E upon E prime was 24. The TR velocity was more than 2.8 at PA pressure of 36. So pretty much you can see that if you look at the E upon E prime was more than 14, the TR velocity was more than 2.8. And if you then we'll go back to the parameters that we're talking about. So more than 14, 2.8, and LAVI, of course, was more than 34 ml per meter square. This is the AR duration, AR minus A duration. So you look at the mitral inflow A duration, which is approximately 190, 116, and this was around 161. So the difference was around 45 milliseconds, more than 30 milliseconds that we were talking about. So in this case, we had all the four parameters which were in favor of the raised LV filling pressures. So this was just a representative case in a case of hypertrophic cardiomyopathy where we are emphasizing especially on the AR minus A as one of the parameters for raised LV filling pressures in case of HCM. Thank you.
Great. Dr. J. C. Mohan, can you say a few, final words and of wisdom, and then we'll wind up?
Right. So thank you, Dr. Singh, for organizing this excellent webinar on diastology new guidelines. Um, I think we need not strictly go by the guidelines in toto. We should use our common sense. We have to use more often left atrial reservoir strain, and we should insist those institutions which have which are placing orders for machines, they should try to get machines which have dedicated software for left atrial reservoir strain. And it is possible to get it at a very reasonable cost, these machines. I am quite aware that the current machines at a very reasonable price provide you left atrial reservoir strain. And also most of these actually are fully automated systems. The third point which I want to say is that many of the things we just discussed, like A duration, AR to difference, and of course the velocity of the AR, and of course Valsalva and things like that. In practice, we don't do it. A simpler way could be actually a leg raise. A lot of these people who have grade 1, you can find out their prognosis. They could become grade 2 with some simple leg raising, because leg raise increases the venous return by about 600 ml per minute, and you can make a huge difference. The stress diastology should be given more importance, especially people who are dyspneic and whose resting parameters are all right, even if the reservoir strain is all right. Keep in mind that Dr. Barry Burlock's study have shown that the reservoir strain has a sensitivity again of 54%. It's nothing. It's not a magic bullet. And actually, although Dr. Singh and Dr. Roberto Long try to sell it as a magic bullet, my submission is don't take it anything as the panacea. You need to, there is a definite role of stress diastology. Do it more often. And I think each lab should have a definite protocol for doing stress diastology in a good number of patients. And lastly, of course, I would say that do not forget the clinical picture. And we do everything, but we forget the clinical picture. And then we sometimes write reports and echo which are incongruous. So my suggestion is look at the patient first, clinical data, and then try to interpret. And don't give dogmatic reports that LA pressure 23.54. Don't do these things. These are not required. We should be actually very humble, saying that the patient has impaired diastolic function with most likely normal LA pressure, or patient has a diastolic dysfunction with elevated left atrial pressure, maybe grade 2 or maybe grade 3, depending upon what you feel like. Those are my words about this.
I think, great, sir. Every good thing has to come to an end. And you guys, I would send Delhi Echo invites with the permission of sir. And we would wish as many people to join and present cases. That's how we learn. And in sir's meeting, it's only cases. There is no lecture, nothing. So I think that's the best platform. And good evening to all the friends. And Dr. JC, sir, Dr. Vinayak, thank you for giving time. Dr. JC had been working back to back with conferences, webinars, and I was scared because we didn't have any communication, but he never failed us ever. So thank you very much. Thank you very much.